Pamela Breyer. I think you're here.
Pam, you're on mute.
Stop. Wait, there's this stupid thing here. I'm trying to, never mind.
Like you're here.
Okay, I'm here anyway. No, you didn't hear me? Ugh.
Yes, we did.
Okay, good. I got it. Press on.
Sorry, the commissioner got kicked off, so we're just gonna give him 1 second to get back on.
There's something weird going on here. Why are you here?
We can hear you, Pam.
I know, I'm just trying to figure out how to get this meeting is being recorded message, which is blocking my screen here.
Sorry about that, folks. I don't know what happened. I just got kicked off. The miracles of technology.
Pam, you have to mark got it, and then it will go away. Just click.
Oh, got it. Got it. Okay, I got it.
Okay, so picking up, we'll start with roll call. Pam Breyer.
Here.
You're here. Dr. Sixto Caro. Dr. Joel Foreman.
Here.
Hello. Rosa Gill.
Here.
Hello. Dr. Sidney Hankerson.
Here.
Dr. Mitch Katz.
Here.
Hi, Mitch. Dr. Simona Kwan.
Here.
Gail Nailwith.
Here.
Karen Redliner.
Here.
And Dr. Lynn Richardson.
Here.
Hi, hello, welcome everyone. This should be a fairly quick meeting. So let's move to approval of the meeting minutes from July 21st, 2021. It looks like, Dr. Foreman, you put something in the chat, but then I got kicked off, so I didn't see it. If you want to put that back in, or if you want to say it verbally, we're happy to take those corrections.
Sure. Thank you very much. I felt necessary to add a couple things. I only found two small things. Page 11, line 19. I think it should be the health code requires the department to either. And on page 22, line 15, it should be the health risks of tanning, not the health of tanning. I couldn't find anything else substantive. And I'm sorry that I had to miss that meeting.
Dr. Vasson, you will learn that Joel is the keeper of perfect minutes because
I've learned already. Yes, indeed. And
very
every
impressive.
good board needs one. And so thank you for your service, Joel, on that front, Dr. Foreman. So if there are we'll make those corrections. If there are no further corrections.
Move adoption.
Very good.
Second.
All those in favor?
Aye.
Okay.
Aye.
Any opposed?
Aye.
Very good. Any opposed? Good. So the minutes from the July 21st meeting are approved and distributed once amended, will be distributed as once amended. So our one item for discussion today, and so which is why we should be relatively brief, is the ratification of the commissioner's order regarding reporting of vaccination for MPV monkeypox. Our presenter today is Dr. Jane Zucker, who is our Assistant Commissioner for the Bureau of Immunization. So I will turn the meeting over to Dr. Zucker now.
Thank you, Commissioner. If we can, excuse me, go to the next slide, please. So I'll start with a brief overview of monkeypox. So monkeypox is a viral infection which is characterized by a rash. In this outbreak, we're mostly seeing the rash characterized by pimples or blisters. This is a virus that is endemic in parts of West and Central Africa. However, since May, there have been human-to-human transmission identified in non-endemic countries. And in New York City, we've had almost 2,800 cases identified, and this is data as of this morning. And also in the current outbreak, which is different than what had been seen previously, the virus is spreading mainly during oral, anal, and vaginal sex and other intimate contact, although the virus can also be spread through direct contact with the rash or sores from someone who does have the virus. Next slide, please. So there are 2 licensed vaccines available, and these are through the US government Strategic National Stockpile to prevent monkeypox. One of them is ACAM 2000, and the other is Jynneos, and I'll mention more about those on the next slide. The Jynneos vaccine is available at several city-run vaccine clinics through mobile units, and also importantly through the provider community. And so that includes hospitals, the federally qualified health centers, as well as some other smaller private sites. So a complete record of immunizations administered is obviously critical. I'd say we've learned that lesson during COVID. It's our way to monitor vaccine uptake, to assist the administering providers, to inform vaccine distribution, to guide our public health outreach and other activities, and also to make sure we can achieve equitable access. However, the New York State law and regulations, as well as the New York City Health Code, do restrict reporting of adult immunizations. Next slide. So this is just a screenshot from our website. Very excited that we were able to post this data publicly. It does show on the left-hand panel a cumulative number of doses that are administered, and that's over 68,000. And then what is really important is the screenshot on the right, which is where we are actually demonstrating how we're doing toward equity, where we're comparing vaccination percent vaccinated compared to the population at risk. And what it shows us is where for example, if we start at the top at age, if we can see that where the 18 to 24 population, and this is from Community Health Survey data, is 12% of the risk population, but we vaccinated 9%. We vaccinated more people 25 to 44, but less in the older age groups. And similarly, there are disparities that we see in race and ethnicity as well as borough. And so this is what's helping to guide the program and why the CIR data is so critical to our effort. Next slide, please. So just a word about the Citywide Immunization Registry. It was started in 1996, and it keeps records of people vaccinated in New York City, as well as some records of New York City residents vaccinated outside the city. We do have data exchange with other jurisdictions. It's accessible in accordance with law to authorized healthcare providers, schools, individuals, and delineated agencies to help ensure people receive all their recommended immunizations. It also provides decision support and notification of when vaccines are due. The schedules have gotten more complicated, and so this is very important. And then CIR records are protected by strict confidentiality laws and rules. Next slide. So for immunization reporting, it's under New York State Public Health Law, Section 2168. And the corresponding rules. So all vaccines that are administered in New York City, and these are to people less than 19 years of age, must be reported. And then all vaccinations that are administered by New York City providers to people 19 and older must be reported to CIR by nurses and pharmacists, but it requires the consent of the recipient. All other providers of adult immunizations may also report, but also requires a consent. And this same language is mirrored in the New York City Health Code, section 11.007. Next. So there are 3 New York orders which have been issued, which are relevant to reporting. The first is the July 29th New York State Executive Order declaring a statewide emergency due to MPV and suspended laws and regulations. And this enabled complete reporting of MPV vaccinations without consent. That was also followed by July 30th by the New York City Commissioner of Health order declaring a public health emergency due to MPV. And then on August 4th, the Commissioner Health order was issued to suspend sections of the Health Code to enable reporting of all MPV immunizations. And this is specifically the consent requirement. And so again, today, where the current resolution seeks to ratify the August 4th Commissioner of Health order. Next slide, please. So this is the specific regulations. It does suspend Article 11 as necessary to require reporting. It does correspond with the changes that were made by New York State to immunization consent and reporting requirements. And I think, and as I've mentioned on previous slides, there are numerous public health benefits, including allowing the department to monitor vaccine coverage, perform targeted outreach to undervaccinated groups, as well as to work with providers who may have vaccine and need assistance in terms of usage of that vaccine, and all with the goal of increasing MPV vaccine coverage across the city and to ensure we achieve our equity goals. And I'll also say some of the other work, we were able to contact vaccinees. So for example, we have already sent text messages to people who are vaccinated to let them know we'll be in touch about second doses. For example, we can send text reminders for second doses. And as an example, we did this regularly through COVID. Next slide. And the proposal is to ratify the August 4th, 2022 order of the commissioner, and I'll turn it back to the commissioner. Thank you.
Thank you, Dr. Zucker. Before I take questions from the board, I just also want to really congratulate Dr. Zucker and her team and Dr. Quinn and the entire leadership of the response. What we didn't talk about was where cases are. While we have 2,000, I believe 700 odd cases, we are actually seeing a pretty steep decline in our epidemic curve. And that's in no small measure due to two things. I think really strong advocacy and uptake of primary prevention messaging leading to behavior modification by, in particular, the affected communities. And this pretty unprecedented vaccination campaign. We've given out more than double the number of vaccinations. And while we are still adhering to a single dose strategy until we adopt second doses, we've gotten the widest group of people some significant level of protection as quickly as possible. And that's in no small measure due to Dr. Zucker, Dr. Quinn, Beth Malden, our other incident commander, and the entire team. We have work to do. Clearly, the data shows that we are not where we want to be in terms of vaccinations in the Bronx, vaccinations amongst African Americans, vaccinations amongst older New Yorkers. And so we have to double down on that. The department has launched some additional funding for community organizations to do outreach, patient navigation, and education. And there's more to come in terms of our support of community-based organizations and community providers that are closer to communities, closer to people, and have a long-standing history of trust, especially with the African American community. So more to do, but a lot to be proud of. And so now I'll just open it up to questions from the board.
Dr. Vasson, you just said a moment ago that we you used the expression double the number, but I wasn't listening right, but double the number of what that you expected?
Oh, sorry, double the number of any other jurisdiction, more than double the number of any other jurisdiction in terms of the number of people vaccinated. Okay. Now, they are partially vaccinated, of course, but we think that there's a pretty significant level of protection conferred by a single dose as a temporizing measure towards a second dose when we have more supply. And obviously, you're probably reading the news and hearing about changes in administration from subcutaneous to intradermal dosing. We're navigating those issues now as we speak, and how that will, on the positive side, expand our supply. On the challenging side, impact a sense of equity and fairness in terms of how we're administering.
Well, I just want to, my last comment, I just want to echo your congratulations to Dr. Zucker, who is fabulous and runs a great team. And it's very reassuring to know all this data. Really, it's great. Congratulations to all of you, even though I know there's more work to be done.
There's more work to be done. And I also just want to thank Mitch and Dr. Katz and his team for their partnership. They've been critical in a couple of areas, some key brick and mortar sites. And they've been key in our PEP program. And they've been key more recently with mobile vaccination, which will be a key part of our equity strategy as well, bringing more resources to the Bronx, bringing more resources to zip codes, African-American predominant zip codes in the city. So thanks a lot to H&H and the team there.
You mentioned, I'm sorry, you mentioned one more question. You mentioned African-American a couple of times, but not the Latino population. Was that for any reason?
Well, interestingly, it's not that it's not important, but we're actually performing fairly well on that metric. We are actually meeting, if not exceeding, the at-risk population in terms of the number of vaccinations given
Great.
out to Latino New Yorkers. So we're doing well for the Asian American community. We're doing well for Latino New Yorkers, but we have a lot of work to do for African Americans. Karen, I see your hand.
Thank you. So Dr. Zucker, that was an interesting overview. The one slide that I was particularly focused on is the data about the distribution of the 68,000 vaccinations. I'm just wondering, I didn't absorb all the information on that slide. Just wondering what is the target number? It seems like you've identified the risk group. What is the target number and we have reached, provided 68,000 vaccinations? Do you have have you identified the risk group and you have a goal of the X number?
So it's actually a hard, I'll let the commissioner chime in, but, I will say one thing that what we're doing now is, right, there's PEP, right, post-exposure prophylaxis for people of known contacts. We're doing this PEP++, which is a sort of people who have had high-risk contacts and high likelihood of being exposed. But what we really want to do is also, once we've gotten that population, and that number was, and the commissioner can correct me because there were some adjustments being made. It was on the order of in the 150,000 range. So, but we want to expand to PEP, right? I mean, that's going to be better. And so that's going to be a much larger group. So I think we do have expanding, we will have actually expanding targets as we go through the vaccination program.
Okay.
Yes, that's right. I think we'll eventually move towards a PrEP strategy. But again, I think why New York City has been leading on this in the nation. We were the first to open this extended PEP clinic in June. And I don't think we'd be here really talking about a national strategy if it wasn't for our push. We really pushed the federal government to take this seriously and to move quickly. But as Dr. Zucker said, the risk group will shift. Right now, we're taking a fairly strict view of the duration of risk, last 12 months, and the nature of exposure, 2 or more sexual partners, 2 or more anonymous or sexual partners. That needs to expand, of course, into other risk groups, and we need to eventually get towards a PrEP model, but that's all constrained by national supply. And while we're great, it's wonderful that we've found a workaround in terms of intradermal dosing in the short term. Longer term, we need to get much more vaccine in the country in order to really adopt a PrEP strategy, but we should be able to do so methodically, and we should be able to do so in a way that while in an environment of falling cases, because I hope we've been able to get people at highest risk vaccinated, even if behavior change doesn't last beyond a certain amount of time.
Okay, that's really helpful. So the vaccine supply is still a problem and is projected to be for a while, right?
Well, it's very tricky to decide what is vaccine supply now that we've switched to this new intradermal dosing. Is it 4 doses per vial? Is it 5 doses per vial? Somewhere in between. One thing is clear is that moving to an intradermal dosing strategy gives us more doses. And so the questions are, there are a lot of technical, logistical, operational, and equity and fairness considerations in terms of implementing an intradermal dose strategy. So we'll be making some announcements in the coming days about how we plan to roll that out, but it's not a light switch that you can flip on and everyone's doing the same thing on the same day. And so we'll get there. Supply does remain relatively constrained nationally, but this obviously helps. I know that there's a lot of vaccine on order for later in the year into 2023 as we think about a wider PrEP-like strategy.
Great. Thank you for that. Thank you.
Dr. Richardson, I think you have your hand up.
Yes, thank you. And I'd like to add my thanks to to Dr. Zucker and her team for the work on this. And we've all, of course, learned a lot from COVID and our efforts with vaccination, particularly in communities of color for that. I just wonder, and perhaps Dr. Zucker can comment on this, how you're approaching the differences in the eligibility criteria for monkeypox. I think particularly the partnering with community-based organizations may need to take a different approach because of perhaps the reluctance of some people who are eligible for the vaccine, who are in the at-risk group, to publicly disclose the behaviors that are putting them at risk. This is very different when we had a high touch, high communication strategy about COVID information. And I'm just wondering how you're thinking about that. I think particularly the partnership with communities is going to be quite different, at least while the current risk criteria are where our vaccination efforts are centered. Can you talk a little bit about that?
Sure. I just want to, Commissioner, would you want to make remarks first? Or I'm happy to start.
Yeah, jump in, Jane, and I'm happy to follow on.
No, so thank you, Dr. Richardson. I think that's just a really essential part of our planning. And we've certainly, we've heard, I mean, we're aware that we've heard that we're really also leaning heavily on the Bureau of HIV and Hepatitis and Sexually Transmitted Infections, who really, as part of their normal work, have very strong partnerships with community-based organizations that serve their community as well as with the providers. So really from very early on, we started working with CBOs to be able to enroll and get their clients, get their patients vaccine appointments, at a number of sites. And then also to acknowledge the mobile program through H&H, where they're actually going out to the community, to community-based organizations where they don't have to worry about, being seen at a health department clinic, being seen at a sexual health clinic, but they're being seen, at another organization, where they already may get some services, and it's done right, not out in the open, being very respectful about privacy also, because we were actually very worried because, the press were going to our pods, right, and looking at who are outside. And so really addressing the privacy issue as well. And I will say for the eligibility, we're not even asking for an attestation, we're just, I'm eligible and that's it, to really lower the bar and not make people feel, like they have to say, yes, I'm gay, or yes, I'm bisexual. But this is, it's just a very easy, I'm eligible for a vaccine and to move on. And so, the other partnerships are with the community engagement teams, and I believe Rima is on with working with, again, venues, that serve this community, whether it's bars, other parties, and, really trying to piggyback on what we've learned for HIV, whether it's with condom distribution, all of those sites, to really get broad, distribution of information and access and information about where people can get vaccinated.
That's great.
Yeah, thank you for that. It is very challenging. And I think the partnerships with, the providers and organizations that are familiar with the HIV and hepatitis at-risk populations is really important. I do think, though, in the Black community, you may need a different strategy. And I would encourage you to think about, and this is partly my bias as an emergency physician, continuing to make the vaccine available at places where people can sort of show up anonymously, going to an HIV clinic or a CBO that services, bisexual and men who have sex with men, it is in itself stigmatizing in some portions of the Black community. Mount Sinai was given some doses of the vaccine, as you know, and our strategy has included making it available in our urgent care centers where people can show up and not be stigmatized. And so I would encourage you to think about including those kinds of places in your in your equity efforts, because it's, as I say, it's very different than trying to do COVID vaccine, and in some ways much more challenging because of the stigma attached with some of the behaviors that are created at this point, at least in the outbreak.
Right.
But again, thanks for your efforts.
Just to build on that point, I think surely we've learned a lot. The folks who did all that work during the AIDS epidemic and now ending the epidemic, there must be a lot of lessons learned. And I think there's just no way to understate the fact that, we're talking about sexual practices here, and all the things that we've learned before, I presume we're doing again. Yes, Jane?
Yeah, I was just going to add one, again, thank you for the comments. I think that's why we also wanted to get vaccine to providers very quickly.
Right.
To, which I'm proud we've been able to do, so that, for exactly those reasons, people can go to a clinic, regular medical clinic. And there's also work, the agency has just funded CBOs as well, to help with that outreach. And then the HIV program, there were similar issues with the HIV program in terms of being able to, whether it's HIV testing in the Black community and outreach. And so they actually have, deep experience in that outreach. And, we're really leaning on them for, to tell us what the best way is to access, the community as well, because, they've worked through, options over many years as it relates to HIV and testing and other sexually transmitted diseases. Absolutely. So I think that point is a really important one.
If I can just add, I think that's where our partnerships with clinical systems have been really important. Mount Sinai, NYP, H&H, they've been really, Northwell, we've gotten vaccine to these big systems. There's another way this cuts as well, which is reluctance to go to big systems and reluctance to go to big institutions and medical systems writ large. So we have to we're trying to balance both of those things, but you're absolutely right. And this is a consistent theme that I'm hearing from advocates, is that there's still a lot of shame. There's still, and it's not, I don't know that we're seeing as much extrinsic shame in terms of the way that people are reacting vis-a-vis something like HIV in its early days, well, frankly, throughout. But we're still seeing a lot of shame in the community, and others can speak to this too if this is their experience. But we're hearing that a lot, and that is causing people to delay or not seek care. And so we have to go really deep, and I think there are trade-offs, right? I think we have to be really clear-eyed about trade-offs. When you stand up a mass vaccination clinic, you get thousands of people vaccinated very quickly. That builds a certain kind of trust in your ability to deliver something consistently with high fidelity to a lot of people at scale. But there's another kind of trust that's about relationships and about being there in non-emergent times and understanding a community. And that's the kind of trust that builds up over time. And that comes, we have found certainly through COVID and other efforts, that comes through the organizations that are always there, right? The organizations that keep showing up for communities day in, day out. And so it's definitely a yes and conversation. The one thing I'll also just bring up for the board, and I've said this publicly, is that we're also dealing with COVID. We're also dealing with now a limited but not trivial polio response. It could get worse, and we're certainly mindful of the risk, and we're doing so with a pretty high vacancy rate throughout the organization. And so we are stretched. Our resources are stretched. Our health systems are stretched, and so I do think that all of that taken into account, gives us a real direction on what to do going forward, but also I'm very, very proud of all that we've accomplished despite those intersecting challenges. Gail, I think you have your hand up.
I do. Thank you, Commissioner. And thank you, Dr. Zucker. It's nice to see you, Jane, moving from COVID to another crisis that deserves your important attention. So thank you for that. Back to this question of stigma, and then obviously we have to vote around the reporting, but the information that you all are putting out on monkeypox is pretty powerful and very good, easy to understand, very available on social media. But there is a relationship, of course, between the public education information that you put out and the stigma that people experience. And one way to get around that and to help people overcome their own reluctance or their shame is to make sure that the information is really ubiquitous. It's available everywhere. And so could you just very quickly talk a little bit about your outreach and engagement, public education wise? The vaccine is one thing, but preventing people from getting sick obviously is another thing. And you're doing a lot of work, but I'm interested in, what kind of tools you're using and how the CBOs can be helpful in that regard too.
Yeah, I'm happy to, and Jane, please jump in. But, one thing is clear is that COVID has really reset people's expectations of when and how they want to hear from public health officials and from public health leaders. And that's both an opportunity and a good thing, but also a kind of a dangerous thing and something we need to use carefully. For instance, we definitely talked about, should we be on the airwaves talking about monkeypox? Should we be putting out PSAs like we did for COVID? But this is not a generalized epidemic. This is not this is not something that we would ordinarily put out general population messaging for. And so we're trying to find the balance between what people are expecting of us in terms of communication, as well as what's indicated. And I don't know that I think we're getting it as right as we can in this kind of transitional phase, but I do think expectations have been fundamentally shifted. And I don't think we're going back to the before times when we would probably run a response like this in a much more, in a much less scrutinized way. I think that scrutiny is good. It brings attention, can bring resources. It also brings some unwanted attention as well that, causes us, just brings that into tension. So that's a broad, high level issue. What we've decided to do is lean heavily into our networks of organizations and community leaders that pre-existed this outbreak and that heavily align with our LGBTQ work, our HIV work, and that allowed us to go extremely deep and do, for instance, pop-up events. It allowed us to get, palm cards and messaging out during Pride weekend or during the Pride parade and related events. It allowed us to go really through trusted organizations and trusted people to start getting primary prevention messaging out there. But what was clear is we also had to go a little bit more broadly. And so, which is why we, had a website put up, which is why we've been putting out bulletins, which is why we have a text line that Dr. Zucker referred to, not just for vaccine appointments, but also for updates and information on guidance and risk. And it's why we're doing a lot of public communications, media and otherwise, that we probably wouldn't ordinarily do, but is now expected of us in any public health crisis. And so that's really been the balance that we've tried to walk. And I don't know that any of us understands exactly where we'll land, but we're just trying to meet the moment for what it is.
Thank you. Thanks so much.
I'd like to call the question, I guess, unless there's more to talk about.
Yeah, that's great. If there are no more questions or comments, can I have a motion to ratify the order?
So moved.
Okay, all in favor?
Aye.
All right,
Aye.
have a second?
Aye.
All in favor? Okay.
Second and I.
Okay, very good. Okay, the motion passes. And with that, we have approval.
Oh, Dr.
Of
Vasson,
the motion by unanimous vote. Yeah, go ahead.
Dr. Vasson, I sort of hesitate to do this because I know that your team is working on a million things, as you say, with not an abundance of staff, but it's hard to listen to this discussion and not remember back pre-COVID to our discussions about ending the epidemic. And I realize that with good reason our attention is shifted, but I am curious, not necessarily for the next board meeting, but at some upcoming board meeting, could we get some report, even if you've put it on the back burner for now? It'd be great for us not to forget about the things that we thought were important a couple of years ago, because I think they're still important, right? And so do you.
I 100% agree. And in fact, when I came into the department, that's one of the first meetings I took was with the Bureau of HIV to kind of review
Right.
the epidemic work. And so that's certainly on my mind. Obviously, we've been pulled in different directions, but
Yeah.
we'll be happy to do an update.
Great.
I'd also be happy to, and this was raised by one of you, I'd be happy to have us all together at some point in the
Yippee.
fall,
Yippee.
either as a pre-meeting or for a formal meeting itself.
That'd be great.
In person, if folks are comfortable with that. Obviously, COVID cases are falling and the ability to gather indoors is becoming hopefully progressively and sustainably safer. And so I'll be reaching out to you and proposing that. And at that time, maybe we can also cover this issue.
Thanks.
So with that, I want to thank you and especially for your service to the board, your service to New York City, your service to the health department, and for making yourselves available. Wishing you all health and safety and adjourning the meeting.
Thank you.
Thank you.
Thank you.